I'm going to be presenting today about neglected tropical diseases, and I called this part 2 because there was part 1 done a few years back, so before either of our classes had begun fellowship training here. So I would like to talk about what are tropical diseases or neglected tropical diseases, talk about some of the epidemiology. I'm going to just talk about a handful of them, particularly the Helminth infection, since they weren't really talked about on the other ID podcast. And then I would like to kind of talk about the ways that we are looking, or that certain global organizations are looking to try to eliminate these diseases on a global scale. So next slide, please. So what is a neglected tropical disease? Neglected tropical diseases, in the widest sense, they're a set of endemic diseases which are most prevalent in developing countries. Collectively, these neglected tropical diseases, which I'll now refer to as NTDs, have unique challenges, and they have limitations for effective preventive and or treatment management, including problems with limited therapies, also toxicity associated with these therapies, sometimes low bioavailability. Sometimes also this is due to the host itself or the infected patient. And then also there's a big problem with trying to target these patient populations, especially if they're living in rural or remote areas. And so applying these treatment or preventive strategies can be difficult. The reason they're called neglected is because they are generally absent from the global health agenda as a whole, and they have limited resources and funding allocated to these by these global agencies. Next slide, please. So these diseases, they're very complex. They often are related to environmental conditions to begin with in endemic areas. Many of the diseases are vector-borne, have either animal reservoirs or also have complex life cycles. And all these characteristics with these neglected tropical diseases make it very difficult to control them, as a public health control is quite challenging for these NTDs. So the epidemiology, the World Health Organization estimates that nearly 1.3 billion individuals, I know I put 1 billion, but the actual statistic I think was closer to 1.3 billion, are affected from NTDs yearly. And so the next slide, I will talk about how we measure this. So Dr. Ehler, could you please advance? All right, so I included this map here. This is from the World Health Organization. It's a really good paper written in 2020. Basically, they had a 10-year plan to try to eliminate or eradicate some of these diseases. But this map is essentially showing the global health, or the global health burden of the NTDs per million inhabitants, and it's measured by it's characterized by a measure called DALYs, which I'll explain right away. And then the next global map below is showing the GDP per capita. And so you can see that the income, or like the kind of wealth of the country, is inversely proportional to the incidence or kind of the disease burden. And so if you just tap enter once or advance by one, Dr. Ehler. So DALY is actually, I wanted to explain this just because we don't really hear about it too much kind of on a day-to-day, but in kind of global health, DALYs are basically measures. They represent the loss of the equivalent of 1 year of full health. And so a DALY is basically a sum of years. It's a complex calculation, but it's a sum of years lost prematurely, plus the years lived with the disability due to prevalent cases of the disease in a certain population in a certain geographical location. DALYs are usually measured in one country or one geographical area. And so the reason they use DALYs instead of just mortality is because it's not only mortality that we're concerned about. And I think also as doctors, we need to know that, just because a patient's alive does not mean that they're doing well. So DALYs kind of take that into account and show the real kind of disease, or the burden of disease. This YLL, this is years of life lost due to mortality. And the years YLD is years lived with disability. And this accounts for, this is actually the product of disability weight, so how severely disabled is a patient, and then also the disorder duration. And so all these factors contribute to this kind of DALY score. Next slide. So what is the problem with the NTDs? Just because we don't see them daily or we don't really have a lot of contact with them, on a global scale, they're quite problematic because they cause, first of all, impaired physical and cognitive development, mother and child illness and death. They cause loss of productivity and reduced socioeconomic and education attainment due to disability. And they also cost countries quite a lot, especially in developing countries, in direct healthcare costs. And so patients who already come from a disadvantaged community or background, they have this cycle of poverty and disease, and it just keeps going. And so this is basically the problem that needs to be addressed. Still, despite all of this and our knowing of these diseases and the work that needs to be done, they are still ranked quite low and are very often absent from global health policy agendas. Next slide. So the World Health Organization listed, I think, about 20 to 23 diseases that are now recognized or included on this neglected tropical disease. It includes viral, bacterial, and parasitic infections. Next slide. So the ones I will be talking about today are highlighted in red. And I've picked these because we don't really come across them that often, just in our kind of general topics. And then I also thought this Drucunculiasis or Guinea worm disease, it's an interesting disease because there's been a lot of progress in trying to eradicate it, and it's actually it has almost been eradicated. We're very close. The other ones, including lymphatic filariasis, Onchocerciasis, Schistosomiasis, and soil-transmitted helminths, are actually on the World Health Organization list to be eliminated by 2023. So along with the other ones, of course, they're trying to control them and trying to eliminate them as well. These ones are kind of their priority at this point. And so I want to explain the difference between eradication and elimination. So we know that eradication, is trying to get permanently reduced to zero all the disease worldwide so that there's no more left. Elimination is really trying to reduce the number of cases of disease or the incidence of disease to zero, and it's usually defined in a specific geographical area. So there's a little bit of a difference, but ideally, eradication would be best. However, that's not always feasible, especially as we'll talk about some of the complex life cycles. And then also, you have to take into account that they have vectors and also different kind of components at play trying to control or eliminate these diseases. Next slide. So the first topic, or the first kind of parasitic infection I'd like to talk about is this Drucunculiasis or Guinea worm disease. I've included the life cycle. Basically, it's transmitted by copepods, which are the vectors, which are small crustaceans in water, in contaminated water. Human will ingest the contaminated water. The copepods will actually die in our GI system. It releases these larvae. The larvae, they then penetrate the gastric and intestinal mucosa. They migrate to the abdominal cavity and retroperitoneal space, and then they migrate through subcutaneous tissue and muscle planes. The mature or fertilized female emerges through the subcutaneous tissues, and then it kind of comes through the tissue, the subcutaneous tissue, as an exit site. And so that's where we kind of see the disease, like physically see it. Next slide. So some of the clinical manifestations, the initial reaction you can have, we would see nausea, vomiting, diarrhea, fever, urticaria, pruritus. You could have a formation of a skin papule, which is oftentimes painful, and it causes debilitating secondary infection. So the primary infection itself, yes, we are concerned about it, but the more worrisome thing is when those nodules rupture or become infected, and those can cause abscess, gangrene. If it's close to a joint, it can also cause debilitating joint disease, and then also sepsis. So the management of Guinea worm disease, it's through slow percutaneous extraction of the adult worm, and you've probably seen this in pictures. I did not want to include it because it's not very sightly, but they basically wind the worm coming from the skin, and they try to extract it that way. And the aim is to try to extract a few centimeters per day until it fully comes out. If parts of the worm are retained, it can cause intense local inflammation, and then obviously wound care with occlusive dressings is important to reduce secondary infections. Next slide. So what the World Health Organization and other global programs have been doing worldwide, there's this thing called the Global Guinea Worm Eradication Program, and it does surveillance and case containment. It prevents contamination of drinking water sources by infected people and or animals. It also provides provision to safe drinking water, vector control, killing the copepod vectors, and using this chemical Temifos or abate, and also educating the community and making sure that the community as a whole is involved in this eradication program. So I included these statistics here that show back in 1986. There were 3 million cases per year, and over the last 30 years or so, about 30 years, there have been less than 25 cases per year through all these kind of different modalities of trying to prevent the disease. And so there are actually now only 5 to 6 countries remaining to eradicate guinea worm disease. So I think that's a huge success for these global health programs. Next slide. The next disease I'm going to talk about, or the next helminth infection, is lymphatic filariasis, which is caused by Wucheria bancrofti and Brugia mallei. And so I've included the transmission and life cycle, as you can see here. So basically, these are nematodes of the lymphatics and subcutaneous tissues. There are 3 major filarial species. So I've mentioned the 2, and there's also Brugia timori. So the transmission is basically by a blood-feeding mosquito vector, and humans are the definitive host. Bancroftian filariasis, the human is the only host. However, in Brugian filariasis, it infects humans as well as domestic and wild animals. And also there's in Africa, the vector is, the mosquitoes differ a little bit. So in Africa, the vector is Anopheles, and in the Americas, it's Culex, Aedes, and Mansonia mosquitoes. So basically, this is okay. And then about 51.4 million people are infected, and that's a statistic from 2018. In the endemic, there are 72 endemic countries in Africa, Americas, Eastern Mediterranean, and Southeast Asia. So I think that's all I really wanted to say about this slide. We can move on. The clinical manifestations. So after you have the infection, so after the larvae start the worms start migrating, they travel to the lymphatics. And so a lot of these manifestations will kind of present because of this. Most infections initially will be asymptomatic or subclinical with lymphatic dysfunction. However, with the filarial lymphadenopathy, which is the acute filarial lymphangitis, we see associated systemic symptoms due to the dying adults generating an inflammatory response with retrograde lymphatic progression. Males will have intrascrotal lymphatic vessel inflammation, or may have. You can also have chyluria, which is rupture of the dilated lymphatic vessels into the renal pelvis, and also producing hematuria and proteinuria. Lymphedema, you can see of the legs, arms, breasts, and genitalia. Recurrent secondary bacterial infections may occur as well. I've included the photo here, basically showing what's called like elephantiasis. So this is the same disease. Next slide. Management. So first, we want to identify microfilaria. They will be isolated from blood versus other fluids, and the peak load is usually at night. ELISA can be used to detect serology of Wolbachia, which is kind of like a bacteria that presents with with filariasis, but also with some other helminth infections. 1 day versus 12-day treatment with this diethylcarbamazine citrate, or DEC. And then you can also target the Wolbachia with doxycycline, and that has been shown to help reduce some of the symptoms, especially like inflammatory symptoms in mild to moderate disease. Lymphedema management is also an important aspect, hygiene to the area, wound care, and then hydrocele, if it occurs, it's only managed by surgery. Next slide, please. So the control of the disease, it's really targeted by the World Health Organization with this global program to eliminate lymphatic filariasis. And the aim is to reduce transmission through preventive chemotherapy. Mass drug administration stops the spread of infection. The used medications are albendazole, DEC, or ivermectin in different combinations. And then you can also, especially if there's associated loiasis or onchocerciasis. So in areas with high numbers, especially in high endemic areas, drugs are usually given to the entire population once a year for 5 years to stop the spread. So it's really kind of like a community spread. So making sure that there's no transmission, I guess, going on by vectors to spread to other people. And vector control and host prevention are also important, especially preventing mosquito bites, surgery for the hydrocele, as mentioned. Next slide, please. So onchocerciasis, this is also called river blindness caused by Onchocerca volvulus. In this, I showed the life cycle and transmission. It's caused by the Similium fly, black fly, as I've shown here. The humans are the only definitive host. This is a species that has separate male and female reproductive organs depending in different individuals. They're transmitted by blood feeding, as mentioned. The black fly will deposit infective third stage larvae subcutaneously. These will subsequently mature into adult parasites or macrofilariae over 6 to 12 months. And the females live in the subcutaneous tissue. or deeper intramuscular tissues surrounded by a fibrous capsule. The males will migrate to fertilized females, producing the microfilariae. And then also an important point is that the ovolvulus can also harbor the Wolbachia bacteria. Next slide. So some of the clinical manifestations, adult worms macrofilaria will aggregate in the subcutaneous and intramuscular tissues, and these can become encapsulated, forming subcutaneous nodules, although they're not usually painful. And I've showed one here on the right. So microfilaria will migrate through subcutaneous, dermal, and ocular, also lymphatic system. When they die, the microfilaria will, the dying microfilaria will cause a clinical inflammatory response, and they actually become like uncovered and expose this Wolbachia, and it's also been thought to be involved in the inflammatory response. The ocular, and all this inflammation, it can infect different organs. The ocular onchocerciasis, you can see punctate keratitis, which can progress to sclerosing keratitis, uveitis, optic atrophy, and chorioretinitis. Onchocercal skin disease can show up as pruritus, depigmentation, also it's been quoted as this leopard skin disease, dermatitis, and lichenified dermatitis and atrophy. Subcutaneous nodules, or onchoceromata, typically occur over the bony prominences of the extremities, but also you can have it on the skull as shown here. And I've also included kind of what this sclerosing keratitis looks like as well. Next slide. So the management, really identification of the microfilaria in the eye or skin. The most common method is actually using skin snip or biopsy. You can do the shaving procedure. You wait 24 hours, incubate the tissue in saline, and then visualize it under a microscope or using PCR if there are no larvae to visualize. Excision of the skin nodule with adult forms. Also ophthalmologic exam, slit lamp examination. And treatment is with ivermectin, and it's repeated every 3 to 6 months until patients are asymptomatic, plus minus doxycycline for Wolbachia for 6 weeks. And then DEC is actually contraindicated due to this Mazzotti reaction. And this is because the dying microfilaria causes acute severe inflammatory reaction, and it can be if there's a high load of the microfilaria, it actually causes it can cause encephalopathy, generalized angioedema, and shock. So very important to make sure that treatment is observed, and it's especially in patients with high loads, and you have to be very careful. Next slide. Control is really aimed at vector control and host prevention. There are preventive chemotherapies administered 1 to 2 doses yearly, and it's more of a community-based approach, like a mass drug administration of ivermectin with adequate coverage for 10 or more years. So it's quite a long, I guess, like a procedure to get everyone to take these medications for 10 or more years. And then I should mention one of these statistics here, the reason I included this map. So by 2019, 1.8 million people no longer required treatment. And some of these areas, as you can see here, like Mexico and in South America as well, they had verified 4 countries for elimination of transmission completely. So still some work to do, but you can see that these programs do work. Next slide. Soil-transmitted helminthiasis. So I just want to talk about this one briefly. It is an important disease. It's a group of diseases caused by intestinal parasites, Ascaris, Trichuris, or whipworm, hookworms, and roundworms. World Health Organization estimates 1.5 billion people are infected, 6,300 deaths reported, and 3.5 million DALYs reported in 2016 in 92 different countries across Africa, Latin America, and Asia. Human transmission, it typically occurs by ingesting eggs or larvae that are found in fecal contaminated soil or water that has come in contact with contaminated soil. So the soil, sorry, this doesn't make sense. Sorry, the soil is contaminated with human fecal material, and then that soil can infect water. So these parasites are transmitted either directly from soil or from ingesting the infected water. Also from contaminated food sources that have been, for example, fruits or vegetables that have come in contact with the infected or contaminated soil or water. Infections result in anemia, malnutrition, impaired physical and cognitive development in children, especially if they have malnutrition, and then also GI symptoms such as diarrhea or abdominal pain, and these are just a few of the symptoms. Next slide. So some of the preventive strategies, preventive chemotherapy. There's also been mass drug administration programs for soil-transmitted helminthiasis. And it's most often aimed at children of preschool to school-age children, using albendazole or mebendazole for Ascaris, whipworm, and hookworm infections 1 to 2 times per year, depending on what the prevalence is in the area. Ivermectin is added if there's a high prevalence of strongy, or if there's a high incidence of whipworm as well. Or sorry, higher prevalence of trichuria. Adequate sanitation and waste management facilities are one of the kind of main ways to prevent this. So making sure that human waste is eliminated appropriately and not getting contaminated in the farming fields and whatnot. Improved hygiene practices and access to safe drinking water, of course, are a common theme among all these conditions, or NTDs. Next slide. So the final helminth infection I'd like to talk about is schistosomiasis. And so I've kind of lumped them all together, but I'll try my best to kind of talk about each one a little bit. So this one I've included, it has a very heavy global disease burden. It's more disabling than it is associated with high mortality. There's chronic illnesses that cause really a devastating kind of socioeconomic status in individuals who have these infections. It causes reduction in work productivity, financial, and also emotional burden when you don't have a way to, take care of yourself and your family. So it's estimated that about 236 million people are infected at any one time. And this is apparent. World Health Organization in 2019 said that this is a growing number over 78 different countries. The global disease burden is estimated 200,000 deaths per year, and then 2.5 million DALYs lost yearly. There are 5 main species. I believe there are 23 species overall, but 5 main ones that we're going to be talking about today. S. mansoni, which is present in Africa and South America. S. hematobium, also in sub-Saharan Africa, Northern Africa, and the Middle East. S. japonicum in China and Southeast Asia. S. intercalatum, and then also this related S. guineensis, which is in Western and Central Africa, S. mekanji in Cambodia and Laos. These species are different based on both the geographical location, but also the vector, the molluscan vectors that transmit them. And then also some of them present differently clinically in terms of the location of the vasculature that they infect. Next slide. So here I've shown the parasite, the transmission and life cycle. I should mention that it's more endemic in rural areas rather than urban areas, just because urban areas typically don't have a lot of fresh water for the immediate or intermediate host to survive. So they don't have these snails or to kind of transmit the disease. The parasite, it rotates between 3 different environmental niches. So one of them will be, or the first will be the freshwater aquatic dwelling, the intermediate molluscan vector, and then it comes into the definitive vertebrate host. And that can be a human or other animal. After several the cercae are released from the snail and into the water, they will penetrate the skin in the human. They then enter this schistosomiasis, which are basically the kind of cercae that have lost their tails. They enter the circulation. The adults actually mature in the circulation. They enter portal blood into the liver. And then that's where the male and female will meet, and they will kind of form a home in the tissue, or in the circulation, I should say, and then they produce the eggs. So they, like I said, they can stay either in the blood or lymphatic vessels. When I should mention that when they do initially enter the body, they will travel to the lungs through the venous circulation, and then go onward into the systemic vasculature. Adult worms, the reason that they can survive so long in the vasculature is that the adult worms, they actually absorb host proteins, and they coat themselves with the host antigens, and this allows them to evade some of the host immune response. The worms will feed on blood, they mature and pair up. This whole process takes about 5 weeks, and then they begin laying their eggs, and the eggs are shed through either the GI or GU tract. Next slide. Some of the clinical manifestations, there's a lot of different conditions that these schistosomiasis can cause. The natural course of disease is quite variable. It depends on the host age of primary exposure. So the younger you are and the more you've been exposed, more inoculum, or whether you've developed immunity to subsequent re-exposures, and then also genetic susceptibility play a part in how the disease will unfold. Some disease can be asymptomatic or subclinical, especially acute this is both acute and chronic diseases. The initial kind of penetration through the skin, through the skin, it can be asymptomatic. Sometimes you can see what's called this swimmer's itch. Acute schistosomiasis, or also called Katayama fever. It's associated with fever, urticarial rash, angioedema, chills, arthralgia, dry cough, and headaches. It occurs about 2 to 8 weeks after the initial exposure, and it can cause lymphadenopathy, liver, spleen enlargement, CNS involvement. It's caused by the hypersensitivity reactions to circulating antigens and immune complexes. It's typically self-limited, and it's more common in travelers, people who are non-immune, rather than people who are living in these endemic areas and who have had exposure previously. Larval worms, they will migrate through lung vasculature and acute infection, as mentioned. They can cause cough, dyspnea, and transient pulmonary infiltrates on imaging. Next slide. Chronic infection, we can see in intestinal or hepatosplenic schistosomiasis, particularly with S. mansoni and japonicum. They have a tropism for the mesenteric venous plexus. They can cause chronic inflammation leading to bowel wall ulceration, hyperplastic polyps, intestinal bleeding, iron deficiency anemia, and then GI symptoms with abdominal pain, poor appetite, diarrhea, and malnutrition. The inflammation of the periportal spaces of the liver is where they kind of sit and reside. It can cause periportal fibrosis, progressing to more generalized liver fibrosis, occlusion of portal veins, resulting in portal hypertension, splenomegaly, and gastrointestinal varices. The next one is urogenital schistosomiasis, which is the one we always see on board exams, is the S. hematobium. And this one, it's caused by adult worms that are residing in venous plexuses of the lower urinary tract, and the eggs will be excreted via the urine. Microscopic, it can result in microscopic or macroscopic hematuria and or pyuria. You can also get bladder neck fibrosis or fibrosis of the bladder generally, causing obstruction, hydroureter, and hydronephrosis. And then we can also see sequelae with bladder squamous cell carcinoma. Female infections can also affect fertility, particularly of the cervix, fallopian tubes, and vagina. You can have fibrosis in those areas. And then very rarely there can also be neuroschistosomiasis, which is it can infect the spinal cord more so than cerebral disease, and we can see acute myelopathy when the spinal cord is involved. And then this was something I found interesting, was that you can actually have embolic CNS egg granulomas. So the egg will actually travel to the CNS and form a space-occupying lesion. Next slide, please. So the diagnosis, it's really based on identifying the different eggs. So the treatment itself doesn't really differ between the species. However, identifying which species, you can see kind of on the figure here that I've included, some of them are the species are very different. So the eggs, for example, in S. mansoni, they have this like lateral spine. In S. hematobium, they have this kind of larger terminal spine. And then the next one in intercalatum has more of a terminal and like the central bulging. And then the other two, Japonicum and Mekonji, are also, they have a less prominent spine and appear more rounded. So here, the way to obtain the specimen is basically to try to get 3 samples on 3 different days. It could be fecal or urine. And then serologic testing or screening, it's more of a screening test for anti-schistosomal antibodies, particularly in travelers, but also can be used in immigrants from endemic areas. And you should wait at least 6 to 8 weeks after their last exposure to make sure that the serologic, like the antibodies, actually show up. This test is very sensitive, but not very specific. Treatment is with praziquantel, which is the gold standard. It results in cure rates of 90% in one single treatment. And it's only effective on adult stages. So when I mentioned that the screening should only be 6 to 8 weeks after, it's because the treatment can only be given after. It's because if you're only, the adult stages, will only, the treatment will only work on adult stages. And so the way to know that there's an adult is if there's an egg. And so that's really one of the limitations to treatment. Dying organisms can also release a lot of antigen load, and this can cause a cytokine release-like syndrome. And then after you give that initial treatment, you should retest for eggs in about 2 to 6 months after to confirm the cure. And this is because the dying organism can actually release the eggs. Next slide, please. So prevention, one of the goals here is to do mass drug administration. And so the goal is to target school-aged children and to kind of prevent the progression of morbidity later in life. And then also these mass drug administrations are used or including adults with occupations which involve them going into contaminated water. And these two populations will receive treatment regularly. Global praziquantel is used, praziquantel is used for treatment globally, so it's the gold standard as mentioned. And there has been some report of resistance, however, it's quite minimal at this time. It is thought that mass drug administration programs can potentially cause an emergence of resistance, especially in highly endemic areas where the disease burden is high, resulting in rapid transmission and then also reinfection. So it's something that we should think about when we're talking about these mass drug administration programs. Other ways to prevent that need to be addressed, obviously access to safe water, sanitation, and management of human waste. Vector control, particularly snail control with molluscicides, physical removal, and then also environment modification. Community education is also very important. Next slide. All right, so ending the neglect of NTDs in these populations. The World Health Organization has created this NTD roadmap to try to eliminate most of these NTDs by 2030. And so the goals of these programs are to strengthen infrastructure and also improve healthcare workforce so that patients can receive primary care in these remote areas. And so essentially the goal is to stop the cycle. One health approach and also stronger collaboration across sectors such as health, water, sanitation, and hygiene, also education and food safety are one of the approaches that are being used. And so it's really, maybe next slide. So you can see here that it really does involve different kind of sectors of the government to come together and try to improve these kind of different, or to try to implement some of these approaches. So obviously the health ministry is very important, but then also other things such as like infrastructure, water and sanitation, agriculture, all these kind of food safety ministries, administrations, they have to work together to try to, in effort to eliminate these. So I've just highlighted some of the ones that we're seeing, and you can see, like, for example, water and vector control will be a very common theme in almost all of the parasites that we talked about today, but it also includes all different ones that are also included at the top there. Next slide. So this one, next slide, please. Yes, so this is again just kind of talking about the different health ministries. So vector control, also one thing I forgot to mention was also kind of dealing with the sequelae of the diseases. So for example, in patients who are already disabled, you'd still have to try to make sure that they have some quality of life, and that we are addressing that as well, and not just the prevention of the disease itself. Next slide. Yes, and I think that's all. Thank you everyone for your attention.